Good afternoon. I'm Joel Williams. I'm thrilled to be here. I'm doing the second session of this Facebook Live. I'm doing these in an effort to help clarify things. I think there's a lot of misconceptions. There's a lot of confusing or sometimes contradictory information that patients come across when they are diagnosed with a hip condition. And I spend a lot of my time in the office unraveling things, clarifying things, and each and every situation is unique, of course, but there are some commonalities. And I think taking some time through this venue is going to be helpful to help clarify a lot of common questions and misconceptions. I'm adding one of my favorite people, Cassie Bolt, live session. She is a patient who's been through PAOs on both hips. The most recent one was just a few months ago, and the other one was a couple years ago. So I think for a lot of questions, it is as important or more important in many regards to hear from somebody who's been through it, rather than hear from a surgeon about what I anticipate, what data suggests. For a lot of the practical questions especially, there's a huge amount of knowledge and experience that can be gained from patients that have been through PAO surgery, or really any surgery for that matter. I think if you're in a traumatic situation, that can be sometimes that's impossible in many situations, but a lot of times in a situation like this, you have time on your side somewhat. I know it's painful, but getting the right information, talking with the right people, getting the right second opinions, I think is paramount. Yeah, I'm going to start with addressing a question that came in from before this live session. If you guys have questions, please put them in the live feed. I'll do my best to address things as they come up. If not, I promise I'll look through them. Some of them are redundant and I will consolidate, and for the next session address any lingering questions that I don't have a chance to ask or answer today. So this first one is, my 17-year-old daughter has bilateral borderline hip dysplasia with some measurements that are in the low 20s and has undergone MRI and CT of the left hip, which shows a small labral tear. She has symptoms while running, going upstairs, and standing for long periods. She has pain on both sides, primarily in her knees, but also in her adductor muscles and groin during more intense activities such as sprinting. She is a cross-country and track athlete. And the questions are there established guidelines or criteria for if and when she might need surgery for dysplasia? And I guess I'll pause there. So with this information, I can't say definitively by any means, even with an abnormal center edge angle, that the symptoms are primarily from the hip or hip dysplasia. I think with an examination and some more discussion and a full review of the imaging, I could commit to that. So for ease of conversation, let's just assume that the picture does sound like it's bilateral dysplasia, left side being more symptomatic than the right. And then the question is, are there established guidelines or criteria for if when she might need surgery for dysplasia? The short answer is no. I think a huge part of it is how bad are the symptoms, how frequently are they occurring, and how severe are they? And really what I'm getting at is how much of a quality of life disruption is being created from the dysplasia. And if somebody, let's take it to one end of the spectrum, is miserable, they can't work, they can't go to school, they can't sleep, they can't walk, clearly that's an abnormal picture. And my next thought is, at 17, this person probably has really good cartilage surfaces, but that's not necessarily true for somebody that's a bit older. And I'm not saying old by any means. I'm saying somebody that's in their 30s, perhaps 40s, then I'm much more critical of the imaging to be sure that this is a hip that's going to do well with preservation. If there's obvious arthritis or even subtle features of arthritis, then my opinion changes drastically at times. So each of these are case by case. So in the situation like this, where somebody's having primarily sports-specific pain, and if activities of daily living are okay, then oftentimes the conversation shifts towards, let's try a pause on running, or in case it's cross-country and track. And that can be a tough conversation for somebody that's in the peak of their athletic career at 17 years old, and they're very much a part of a team. But in all honesty, if it were my kid, that would be the first thing, is let's take a break from whatever the offending sport or activity is and see how the pain does. And if it resolves, then that can be an acceptable treatment for a period of time. If the pain is still there, the pain worsens and is now infiltrating everyday life, then that's a time where I think surgery is more appropriate to discuss. I think it's great, but there are many surgeons that will say no surgery, sports only type pain is a non-surgical scenario. And I think each case is important to take case by case. The next question is, given that she's still able to run, how should her current symptoms be interpreted in terms of progression risk? And I guess for progression, it's unlikely or it's rare that those numbers that we use to assess coverage, meaning how much socket is sitting over the ball, like those numbers might change a small amount once somebody's reached skeletal maturity, but they tend to be fairly fixed. So progression in this context might might mean progression of her cartilage integrity or progression to arthritis. And I think that's a tough one. There's an assumption, I think it's fairly on point, that pain equates to damage. There isn't data to support that point, but if somebody's having pain and they have a structural issue, my general advice in that scenario is listen to your body. Anything that's in your groin, in your pocket area, in this general part of your body, from your bottom of your rib cage through mid-thigh, that can be the hip. And for somebody with a structural issue, that's oftentimes something that explains it. And my advice is to hold off, to avoid the activities that predictably produce pain. The next question is, when she races, her pain's a 7 out of 10, but resolves with rest. How likely is her condition to worsen over time, or can it remain stable for a while? And again, this is related to identifying and ideally eliminating any exacerbating factors. And it's a tough conversation for many patients, but it's something that I think it's important. The last one related to this scenario is considering my experience with my oldest daughter who had PAO surgery for dysplasia due to daily pain. Earlier surgical intervention in high school be advisable if her condition progresses. Reinhold Gans is the sort of godfather of preservation, and I don't know whether he published this or this is just hearsay, but he's known to have said something along the lines of the ideal time to intervene is the first day after pain. And really what that means is back to the statement I made before about ongoing pain equates to damage. In theory, if somebody's diagnosed with a structural issue and it's symptomatic, the ideal time to intervene before damage accrues is right when it's diagnosed. But a lot of times it's very different than tearing an ACL or breaking an ankle. The symptoms with dysplasia tend to be much more gradual or insidious, and patients often struggle to say, it was on this day at this moment during this play or this maneuver. It was 2 years ago, I think, and things have gradually gotten worse. That's much more common. So I think when the writing's on the wall and there's a pattern and we've clearly identified that this is symptomatic structural hip disease that's affecting people's quality of life and not just sports but activities of daily living, then yes, I think that's earlier is better. And that doesn't mean we have to rush off to surgery tomorrow, but to prevent the cartilage damage from accruing, yes, I think sooner is better than waiting. The overarching theme for today, and I'm going to try to keep it a little bit theme-based, is, what are some common myths or misconceptions about PAO surgery? I often get patients that have come in to the office, they've already got a diagnosis, they've already heard some of the treatment options. Many have already been through and failed a hip scope, and the internet is filled with information, not just on dysplasia, obviously, but on anything and everything under the sun. So there's some really good information on the internet, and there's some not so good information on the internet. I'd say people come in with various amounts of information. And one of the most common questions or common misconceptions or myths that I have to sort of unravel is that they have a torn labrum, so they need a scope to fix the labrum. Somebody comes in already having been diagnosed with dysplasia, sometimes impingement, and oftentimes a labrum. And there are some situations where I think if you showed the MRI to experienced hip surgeons or radiologists, we could all agree that there's a torn labrum. That's an uncommon situation, I'd say. It definitely occurs, but I'd say it's more common that I look at the MRI, especially in a young person, and the labrum looks irritated, or there's some abnormal signal within it. But based on the MRI, I often find it difficult to say definitively this labrum's torn, detached from the rim of the socket, and it looks unstable. So that's point one. Is there are many times where it's called a labral tear on the MRI, but it's still a little bit gray in my mind. Even for patients that have a labral tear that we can all agree on the MRI, there is an evolving amount of literature or data on this exact topic. And let me just back up a minute and zoom out. Historically, especially when this procedure was described 40 plus years ago, people weren't getting MRIs and people weren't routinely having their labrum addressed. And the results of PAO surgery were really good. In most parts of the world, I'd say it's uncommon to have a scope done to fix a labral tear in addition to the PAO if the primary pathology is dysplasia. So if somebody's primary structural issue is dysplasia, they have a labral tear, the historical norm, the vast majority of patients that have ever undergone PAO surgery didn't get an MRI or their labrum fixed. And on the whole, people get good outcomes. In many parts of the world, same thing is true. So hip arthroscopy has advanced astronomically in the past probably 20 years. And the real question is, can we improve the results of PAO surgery for somebody with dysplasia if we add a scope at the time of the PAO or just before the PAO, like a week or two in front of time, a week or two ahead of time? And the short answer is our data right now suggests that when you look at a group of patients that have been through a PAO alone and compare them to a group of patients that have been through a PAO plus a hip scope, the results, at least for the short term, is the same. So I think for many patients, adding a scope is overkill. I think that's not true for all patients. So I and the surgeons here at Rush that take care of young adult hip problems take each and every case as a unique one. And we will be honest in saying, you are somebody where I feel strongly that a scope should be part of your plan. Or no, I think a scope is overkill. There's a chance that an anchor ends up in the joint. There's a chance of adhesions or scar tissue forming inside the joint. So it's not a zero risk thing. So we're very deliberate and very cautious about who exactly is likely to benefit from the scope versus who's somebody like a patient that may not a scope PAO combo candidate. If somebody has features of impingement, which is a structural problem but different than dysplasia. In impingement, you can think of as too much contact. The amount of socket covering the ball looks good, but there might be some extra bone on the femoral side or on the socket side, which needs to be shaved down. That's also a situation that's frequently accompanied by a labral tear. That's a situation that can be treated effectively many times with physical therapy. And even though the labrum doesn't fully heal or go away, the symptoms calm down and patients can have a good result. When that doesn't work and we're talking about surgery, the historical norm and the gold standard is what's called a surgical hip dislocation. And for a lot of the very severe impingement pathologies, that is still a procedure that exists and part of my armamentarium, but I do it less and less every year because people are getting better and better at hip arthroscopy. So I don't think it's ever going to be an antiquated procedure, but I think the frequency that we're doing it will continue to go down or plateau eventually because arthroscopic techniques continue to improve. That is a situation where I think it can be very effectively treated arthroscopically with a labral repair and some shaving and some extra bone wherever it's appropriate. But knowing the difference between the two and then oftentimes figuring out for somebody that has features of both impingement and dysplasia, what's the primary problem, primary pathology can be very difficult. And if it comes down to being a dysplasia or instability type problem, then that's what's relevant to what I started with, which is it's unclear whether or not fixing the labrum is going to change the outcome for the long haul. And some patients, I think the answer is yes. For some patients, I think the answer is no. All right, so I went through a question that I didn't have a chance at answering last time. It was a 17-year-old patient. And then I started going down the sort of myths, misconceptions that we talked about beforehand. Just finished talking about why not just do a scope? My labrum's torn. Do I need to fix the labrum in that conversation? And it's case by case is the short version. I think, Cassie, correct me if I'm wrong, both of your PAOs were accompanied by a scope just before the PAO, is that right?
That's correct, yeah.
Yeah, and I think for many patients, the other side to this is, okay, let's say many patients don't need a scope. And we go through a PAO, we go through that whole surgery, that whole recovery. 6 months passes, people go back to sports, increase their activity, and then all of a sudden, if their pain comes back, that's when, in some medical centers, in some countries, in fact, that's when they consider a scope. And that's rough because you've just been through a big surgery, a big recovery. And the last thing that anybody wants to hear, the last surgeon wants to say is, I think we should do another surgery to fix your labrum, when that could have been part of the plan right up front.
Yeah, and that was why I ultimately to do the scopes before too. But yeah, same thing. I did not want to have to worry about needing a second surgery, any point in the future.
Yeah. And then the only other thing I'll add is it depends on what the specific reason is to be inside somebody's joint. I think it's fair to say that experienced hands being able to look at and fix a labral tear is better with the hip joint distracted arthroscopic. That way you can look above and below the labrum. If, however, the primary reason to be in the joint is some extra bone, let's say it's impingement plus dysplasia, shaving down extra bone on the femoral side can be done effectively open, or meaning during the PAO, we can open the capsule, which is called an arthrotomy. And that used to be much more common historically than it is now. So there are various ways, and I don't want to get too stuck in the weeds on this, but the work inside the joint should be taken on a case-by-case basis. I do think that doing intra-articular work or things inside the hip will help many patients, but it's overkill for some. And I think it's important to get an opinion from somebody that understands all these nuances rather than just saying, this is the protocol for your situation, and looking at it a little bit more closely. Another common misconception or myth is, I want to just skip the preservation. I want to just jump to a replacement. I have a family member, a friend that got a replacement, and rather than go through this big surgery, big recovery, and be on crutches for 2 or 3 months, let's just skip that and jump to replacement. Did you come across anything like that in either seeing surgeons, physical therapists were reading about that ahead of time, Cassie?
I didn't personally because I went to Dr. Chawla. I thought I just had a torn labrum and I was going to get that fixed and be on my way. But thankfully he caught the dysplasia and sent me to you. But I do hear it very commonly talked about in other people of a certain age in the Facebook groups, especially saying how easy a hip replacement would be compared to a PAO. And some surgeons say, oh, just wait 5 or 10 years until you're bone on bone and then come back and we'll replace it.
Yeah, I get that one a lot. And there's some truth in there. I think if somebody's made it to their 40s and they're just now developing symptoms of dysplasia, and we confirm that the location of their pain is their hip joint, we go through the imaging, and they already have arthritis. If they already have full bitten arthritis everywhere, that's a situation where I do think replacement's a better option. How much arthritis is too much is a really difficult question to answer. It depends on so many considerations, but there's a large gray area, and it depends on expectations. It depends on what somebody's goals are. So if somebody wants to be really active afterwards, that's important. But I think an important thing to really help put things into context is a hip replacement is taking out the hip joint we were born with, putting in metal and plastic. I have a model. I don't know if this is going to project very well, but it is taking out, so this part of the femur, the upper end of the thigh bone, has been removed and metal and plastic go in. And it's a combination of metal, plastic, and ceramic many times. And it's a mechanical device. And the last time that there was a major change to the modern hip replacement was 20 plus years ago. And it was for good reason. I think the weak link previously was plastic. And as time's gone on, the plastic has improved. But it's still a mechanical thing, analogous to a new set of shoes or a new set of tires, that if you use it enough, it's going to wear. And at this point, the 20 to 25 year mark tends to be what I tell patients in terms of how long a hip replacement will last. That's not true for everybody. There are some people that have a hip replacement and it lasts 40 plus years. And there are some patients, especially younger, more active patients, that get a hip replacement done and it wears out prematurely, or there's some reason to do a secondary operation. And the results of primary, meaning first go hip replacement, are really good. The recovery is really short. And these are the things that a lot of patients are seeing online or being exposed to. But it's a whole different ball of wax when they have a revision hip replacement. I think if you're exchanging just 2 of the parts, not all 4 parts, that's best case scenario. But there are times where all 4 parts need to be exchanged, and that can be identified before surgery or unfortunately sometimes in the operating room. And that's what we're trying to avoid. So there's, I'd say, 2 reasons why we don't just jump straight to replacement. That's one, is it's going to wear out. Revision replacement is the results of revision replacement are inferior to primary replacement, and the complication rates are higher. So as long as that's still true, there's still going to be a role for preservation. And the other is, I think as long as somebody doesn't have arthritis or preservation, the activity levels and being able to get back to sports after a well-done PAO tends to be better than somebody who's had a hip replacement. And that's a generalization. There are exceptions to both sides, but I think that's an important thing to understand. So if somebody's in their 40s, they have a touch of arthritis, they have no interest in doing anything athletically, is there a role for discussing replacement? Absolutely. On the other hand, that same age patient who wants to go back and be really active at the gym and doesn't have any arthritis, ideally, maybe they likely have a labral tear by that point in life. That's somebody who I think is probably better served with a preservation. And that's really hard to tease out. It's impossible, to make blanket statements that everybody over the age of X or under the age of X should get this or that. I think each one's case by case, and it makes sense to see somebody that's going to give you unvarnished set of recommendations and say, here's option 1, here's a scope alone, it may buy you some time. Here's a PAO alone, here's a scope and PAO, here's a hip replacement. Be able to touch on all those different options when it's appropriate. Many times if I see somebody that's young, that hasn't had symptoms for a long time, their labrum looks okay on the MRI, that's over. Like it's going to be in all likelihood a PAO recommendation, based on, all those factors we just went over.
Yep. I totally appreciate how you look at everything too. I know for my second hip, I was kind of like, how much time do I have? Because I didn't want to go the total hip route. So I like that you don't have a cap on the age specifically.
Yeah, I think the youngest patient we've done is in the teens. I want to say 14, or I'll say 13 or 14. And the oldest I think is 46 roughly. I have some colleagues that have done PAOs on patients in their early 50s, and it's case by case. It's more so about the mileage, not the year. The MRI helps with looking at that. So yeah, I think it's important to take each one on a case by case basis. That's related to myth or misconception number 3, which we had talked about, which is patients over 40 should have hip preservation and get a total hip. And I don't want to belabor it, but those are my thoughts on those specifics. There's absolutely a role for hip arthroscopy. There's absolutely a role for replacement, but I think taking each situation as a case by case makes a lot of sense. Anything to add?
I think you nailed it there.
Okay, some other questions came up last time that I didn't have a chance to address. One that came up from Olivia Potter is, why is the recovery so long? Like we just talked about, hip replacement is a whole different animal. Like hip replacement is often done on an outpatient basis. People come back to the office around 2 weeks for their first post-op check, and many times they're done or almost done using crutches or a walker, which sounds a little bit different than what you went through, right?
Yes. Even PAO to PAO, the initial recovery was easier the second time, but then coming off the crutches has been harder, which I did not expect. So I have had that feeling of this is lasting forever, just to get back to normal walking.
But I'd say on the whole, a PAO and a hip scope for that matter, it's a longer recovery than a hip replacement. So here's the same model. Here's the socket. Here's the ball. This is all removed in a replacement, and metal is put into the femur. Ceramic is usually on top. Sometimes it's a metal ball. And then it's a metal ball with a plastic liner that's put into the pelvis. So a lot of the painful nerve endings are within the bone, within the labrum, and those tissues are removed. So the native tissues come out. So the reduction in pain, I think, is a lot faster for that reason. And in all preservation surgeries, all of the native hip tissues are still there. Like torn things are repaired, damaged things are repaired as best possible, but it takes time for that pain complex to really calm down. The surgical insult, I'd say, is about the same between a PAO and a total hip. We're in the same ballpark. But they're both major surgeries where we're cutting bones. And I think the major difference, at least in terms of pain reduction, is you're keeping all of the hip tissues with nerve endings in preservation, and that takes time for that to calm down. And a lot of times when I'm correcting a structural problem, like a PAO or a femoral osteotomy, it takes time for your body to adapt to that new structural change. It's a much longer answer than that. But for the most part, yes, I think recovery after replacement is faster and preservation is a longer road, more of an investment. How long does a hip replacement last? Short version is, at this moment, my interpretation of the data is I'm telling patients 20 to 25 years, but keep in mind that's an average, could be shorter, could be longer. How often do I have to do revision PAOs is the next question. It's very uncommon. I think most people that choose to add PAO surgery to their practice are dedicated to it, and they're doing the appropriate training, they're doing appropriate surgery, and ideally they're putting the hip socket in a really good position. And if that's true and things heal and we've avoided infection, we've avoided non-union, we've avoided any of the potential complications, and somebody has a bad result, let's say, sure, like are there times where I've seen post-operative x-rays and thought to myself, this should be a little bit better? Yes. But is it bad enough that I think it's in the patient's best interest to undergo a revision? It's uncommon. It's not unheard of. There's definitely publications on it, but it's rare. Short answer is very, very uncommon. Another one that came up is when I was reviewing my paperwork regarding managing pain and activity until surgery, it says to monitor pain, but if you experience pain in the groin, to stop. What does this mean? What type of pain? Shooting pain, soreness, etc. I think that's good advice overall. I think it's based on the assumption that pain equates to damage. For patients that have been diagnosed with a structural hip problem, my general advice is don't power through it. If you're experiencing pain in the groin, on the outside, sort of by your front pocket, by your back pocket, low back, down to your mid-thigh, in that neighborhood, if you have a structural problem, my advice is back off. And if you can find some way to stay active and to stay pain-free, by all means, keep going with whatever activities you're doing. But if you're experiencing pain and you have a structural problem and you have a hip that's amenable to preservation, my advice is to stop. And that's regardless of all the different types of pain that this person asks about. So it doesn't really matter, in my opinion, whether it's burning, shooting, dull, aching, throbbing, stabbing. Like, the quality can be helpful with some sort of higher level thought processes in the office. But my general advice is, regardless of the quality of the pain, if it's in the ballpark of your hip, just listen to your body and back off or modify your activities. The next question, I want Cassie to take a swing at first. Is it common to have both hips done or just one? And that could mean one of two things. That could mean, how often do patients have symptomatic hip dysplasia? Or a lot of times the question that I get is, I have pain on both sides. You've diagnosed me with dysplasia on both sides. Can we just do them together so that I have one recovery? So now that you've been through two different surgeries, Cassie, what are your thoughts on that if we did both on the same day?
Oh, geez, there's no way. No, you wouldn't be able to move for a long time. So definitely no to that. Very much liked having my one good leg leg, even if, it wasn't perfect, but
Yeah, that's my general thoughts on it too. I don't know of anybody that's recommending that. And it's quite literally that. You need a good leg to stand on, even if it's a less good leg, to make the recovery happen. Otherwise, you'd be in a wheelchair and your recovery wouldn't be like 1+1=2. It'd be like 1+1 is like 10. So it would last a lot longer. I think the end result wouldn't be as good. I love it theoretically, and sometimes we do that. There are some surgeons and centers that are, I don't want to say routinely, but they're still proponents of doing bilateral knee replacement surgery or bilateral hip replacement surgery, but this is just a different animal because the recovery.
And on that point too, it would take away like all of your independence, all of it. And I will say personally, I liked being able to get up and move, especially like after like 2 weeks-ish, you sort of turn a corner and then, I'd maybe unload the dishwasher or something. I could help with little tasks, and it very much helped like my mental health personally.
How long would you say that you needed somebody, like I know you're dependent on somebody the entire time you're on crutches in some capacity, but it's, in different phases, right? Like the first couple weeks, like how long would you say that first phase was where you felt totally dependent on somebody else?
I would say like the first week after being discharged from the hospital, like that first whole week is definitely, you need help making sure. Also, we have a lot of stairs. So my husband would travel with me up and down the stairs, especially being on, the narcotics and that sort of thing. He wanted to make sure I was safe getting upstairs and downstairs. And then, just getting food, a lot of things, getting dressed, getting into the CPM machine is difficult on your own for, I would say, like those first 2 weeks, like when you're in the hospital, and then at least a full next week after you're discharged.
And my protocol is pretty similar to the national norm, which is 6 weeks-ish on crutches. I know some people that are trying to shorten it to around 4 weeks. It used to be more common to hear 8 weeks, but let's just say 6 weeks is the norm. At what point were you chomping at the bit and getting frustrated that this first phase wasn't ending? Is it like just the time point you're describing?
Probably like 4 to 6 weeks is when you're really starting to get anxious. Like, okay, I can do more, but I still have to be on the crutches. Like, I know for me, I grabbed my laundry bag out of our camper and I would help with laundry. I could take it downstairs and start it and flip it, but then I couldn't carry a basket upstairs. And so it would just be little things. And I'm like, man, I can't wait to have my 2 hands and walk. But definitely turn that first corner around like 1.5 to 2 weeks post-op though.
And then I guess read differently, is it common to have both hips done or just one? And that's one that I can't, the answer is yes and yes. I see some patients that have radiographic dysplasia on both hips, and for reasons that I can't fully understand, one side hurts and the other one doesn't. I'd say it's more common that when somebody shows up with dysplasia on both sides, if they're not both symptomatic right when they show up, a fairly high percentage of patients at some point in the near term develop symptoms. I wish I could better explain or predict, that, but there are many things that we understand about the hip and hip preservation. That's one of those things that at least I admittedly don't have a firm grasp on, or how to predict who's likely to be fine with the other hip versus who's somebody that's going to flare up while they're recovering after the first one or at some later point. It's common, or it's not common knowledge. It's a condition which affects women much more so than men. And when pregnancy happens, all of the ligaments in our body, all the soft tissues in our body become much more elastic, as they should, to help with delivery. And that also can exacerbate somebody's pain that has underlying dysplasia. So that's another thing, is sometimes I'll see patients that are coming in with an infant, like a newborn. Like, I had no idea that I had dysplasia until I was pregnant, and then all of a sudden my body did what it was supposed to do, which is relax and like make all the soft tissues more elastic. And then all of a sudden somebody that's had dysplasia radiographically for a long time just became symptomatic. So I'd say ways in which asymptomatic or minimally symptomatic dysplasia flares up is when you're recovering on one, like on your other side, or pregnancy when it relaxes all the soft tissues. One is, if a patient has impingement in addition to dysplasia, how does that change or complicate the PAO? That's a really good question, and that's a really nuanced question. The diagnosis of impingement and dysplasia, for that matter, are radiographic measurements where we get appropriate imaging, draw lines, make angles on the screen. But the reality is we're looking at a static, a non-mobile, two-dimensional set of imaging a lot of times, and trying to understand what's happening in a three-dimensional structure while it's moving. So when somebody comes in that meets the diagnostic criteria, both impingement and dysplasia, I'm looking really closely at the advanced imaging, like the CT and the MRI, to help me figure out, is this hip behaving like an impingement hip or dysplasia hip? Or if I'm not sure, I'll be honest and tell the patient, I'm not sure. You got features of both. And, just because you meet the diagnostic criteria based on the x-rays doesn't mean that needs to be an important part of the plan for every every single patient. I think it depends a lot on the rest of the anatomy. So the most common, the most relevant type of impingement that we're talking about is what's called CAM, femoral-sided impingement. I'm going to pull up the models, Cassie. Ready? And that means, so I'm going to put this closer to the screen. Marisol, tell me too close. So femoral-sided impingement means that this area, so where the head transitions to the neck, and I'm showing you the back of the hip right now, shows a pretty nice recess. It looks sort of like a light bulb, and it's more elongated in the front. And when it's elongated and there's too much bone, like the short version of that is that called CAM type impingement. Does everybody that has a CAM have symptoms? No. It is CAM plus activity plus the rest of the anatomy, which usually creates an impingement. So somebody has a CAM, but the rest of their femur, let's say their femur has a really abnormal twist like this to it, even if they have a CAM, which is right here, the position that their hip has to be in for that CAM to be relevant tends to be pretty extreme. So for somebody that's a gymnast or a dancer or a cheerleader or a martial artist, yes, that might be a relevant CAM or impingement type layer on top of their underlying dysplasia. But if somebody has a really mild abnormality and they're not one of the athletes or not trying to do the things that I just mentioned or test the extremes of their hip range of motion, which you can think of those activities as ones where your foot's way off the ground, way up in space and moving around. So that's a bit of a unique situation. It's a small percentage of physical activity expectations, but for the most part, people aren't listing those as their activity they want to get back. So outside of those exact situations where you need a full, like maximal hip range of motion, my next question is the CAM relevant? Is it engaging the hip socket or the rim of the hip socket throughout the arc of motion? Is it pushing on the labrum? Is it creating an issue with the labrum where it attaches to the rim, which is where the cartilage edge begins? So all those things have to be taken into account rather than just say your measurements meet these criteria, your measurements meet those criteria, we should do both. I think the problem in thinking about it that way is you're going to do a lot more surgery and do a lot more steps, which comes with more risk and potentially more complications if you're doing the kitchen sink approach in every single patient. Next question's from Carla Junko. Does the PAO decrease the hips range of motion or flexibility afterwards? Short answer is yes. Long answer is it depends on the rest of the anatomy. So there are certain types of dysplasia where it's called retroversion of the hip socket, which means the socket's backwards facing instead of forwards facing. That generally correlates with more external rotation where the foot points outward and decreased internal rotation where the foot goes inward. And the opposite's true. So some patients have dysplasia but lots of anaversion. The clinical picture is that of somebody many times with an in-toeing gait where they have lots of internal rotation and decreased external rotation. So when I'm thinking about the optimal position or the optimal reorientation for somebody's socket, it's factoring in what is their range of motion, what does their gait examination look like. That's why I get everybody to take a lap up and down the hallway so I can see how they walk. I can test their range of motion and see how they move. As a general statement, yes, range of motion tends to go down a small amount for most patients to get a PAO. For the athletes that are trying to test the extremes of motion, again, common examples are gymnastics, cheerleading, martial arts. I think there is a noticeable decrease in motion sometimes, and that can affect performance. So that's part of the conversation ahead of time. The things that we can do to help retain motion are if there is a CAM, so for this patient with a mixed dysplasia impingement picture, shave down the extra bone here and be really critical of what is their anaversion or anatorsion of their femur. And if somebody gets a PAO and they lose motion and they think it's going to affect their performance, that might mean I have a lower threshold to also recommend a femoral osteotomy to help increase internal rotation oftentimes, but that comes with a decrease in their external rotation. So I'm robbing Peter to pay Paul. And each of those considerations have to be taken on a case-by-case basis. So that's answer one. Answer two is everybody after every operation forms scar. And the amount of scar that you form depends on the surgical technique, but I think more importantly, it depends on genetics. Some people just form a lot of scar. Some people form very little scar. And that's the biggest determinant, I think, or a major determinant on how well somebody preserves their motion versus has a restriction in their range of motion once the recovery is done.
And
Physical therapy. Sorry, go ahead. Physical therapy is also the third component to that.
Yeah, I was just going to say, I haven't noticed anything significant as far as loss of range of motion in my daily life.
That's because you had Megan as your physical therapist.
I wish, but she's too far away.
Oh, right. That's right.
I do run stuff by her, though, a lot. So make sure my physical therapist is on point here.
Good. Okay, last question. Is there a benefit to doing a scope ahead of time? So if you missed the explanation about the role of arthroscopy and dysplasia, we're going to save this. You can rewind it and watch that explanation. Another question that I often get is, does it matter whether the scope scope happens the same day of the same trip to the OR as the PAO, or if we do it in advance, like a week or two ahead of time, and the recoveries are coupled together, will that matter? Does that impact my outcome? That is thus far an unanswered question in the hip preservation literature. We've done it both ways, and I think the short answer is no. I think if there is a role for arthroscopy and we think that is going to be a key part of improving somebody's outcome, whether it's done the same day or a week or two ahead of time, I don't think matters in terms of the big picture outcome or the results at 6 months or a year or even after that. I think there are many considerations into how we think about that. And for somebody that has a solid skill set in arthroscopy and PAO surgery, you can make a strong argument that that should be done all at the same go. There are many people that, while training, really focused on one or the other. And my focus throughout training was much more on the open side of preservation. And I've come to realize that, there's an evolving and growing role for arthroscopy, and that's a deficit in my skill set. So that is something that I'm working on and doing some additional training, in fact, to add that for patients where it makes sense. But the short answer to your question, and this is from Tino and Danielle Solis, is the recommendation to add a scope for somebody with dysplasia is taken on a case-by-case basis. But if your surgeon's saying, listen, we should do it together, or I think it's best for you to break them up and do them on 2 separate days, I don't think that's an important consideration. So Dr. Chawla did both of your scopes, is that right?
Yep.
Roughly a week or two ahead of time?
Yeah, about 2 weeks.
Yeah. And by the time you come back, so like the scope happens, you come back for the PAO, you've been on crutches for 2 weeks. So I guess that is a small downside, is your recovery, the portion of your recovery on crutches is 2 weeks longer than it could have been had we done them together.
Yeah, but it's not as bad. The pain is a lot more minimal. You're up and about as much as you can on crutches pretty soon after. Like, I know I was a week and a half after and walking more steps on the crutches than I currently am now without crutches. So, and I think almost 12 weeks out from my PAO.
Great. I think we should wrap it up there. Is there anything else that came up where that you think would be good to add while we have?
Not necessarily, just basically listen to your body if you do end up going the PAO route for hip dysplasia, and move when you're able to, and ice a lot. Like, all of the recommendations, I say listen to them. But yeah, that's about it.
Okay. Well, thanks everybody for tuning in. Keep questions coming. Like, even at the end of this, this will be posted. You can comment below, add questions. We'll look at them. We'll summarize them, consolidate, some of the repetitive ones, and appreciate everybody's time and attention. And if there's anything else, any other suggestions for the next Facebook Live sort of theme or topic, just let us know and we can try to put something together. We'll probably plan to do another one in a couple months, and hopefully we get lots of questions between now and then.
Thank you.
Thanks, Cassie.
Yeah.
Yeah.